Hey everybody, welcome back to the ECG of the day. My name is Reed, and before we get started, don't forget that you can download this PDF document, which is down in the description below. And don't forget to like and subscribe to the channel if you enjoy the content. So let's go ahead and get started. So the first thing I like to do with every ECG is begin by looking at the forest, and the trees of the forest are my QRS complexes. And so if I come down here maybe to V5, you see I've got my baseline rhythm, or these wide complex QRSs, right? You see one here at the beginning of the strip. So we've got a wide complex rhythm that is regular. And you have probably noticed very quickly that there's this odd looking beat that is different morphology than the baseline beat. That happens a couple times. And after each time, there's a little bit of a pause, and then you see the rhythm continues again, right? Kind of back in our regular rhythm. So we've got a regular wide complex rhythm. And so we think that's either one, a ventricular rhythm, or two, it could be a normal sinus rhythm with aberrancy. So it could be an aberrant rhythm. I feel like there's maybe one R's. An aberrant rhythm. I don't know, maybe two. Alrighty, so regardless, so we got either a ventricular rhythm or an aberrant rhythm from the atrium. So I take a glance and I see, well, are there P waves in front of my QRSs? And it appears that there are. You can see there's some P waves here in front of my QRS complexes. You can see them in V1. So I wonder maybe these are some sinus P waves. So my question now is, what is the atria doing? Is there atrial activity in front of these ventricular beats? And so I do see that there are P waves that are right here in lead one. You can see upright barely, just barely upright in lead one. And you can see AVF. You can see we've got a nice upright P wave in AVF. So I would say that these do appear to be like sinus P waves that are occurring in front of my wide complex QRS, right? So ideally, that means that we've got the sinus node firing off, depolarizing down and to the left. And so now we think that maybe the AV node captures that, sends it down to the ventricles, but it does it with an aberrancy, which is why my QRS is a little bit wide. So the next thing to do is to now evaluate my PR interval, which represents my AV node. So what is my AV node doing after the sinus node beats? And so you can see that my PR interval, if I measure here, my PR interval looks to be about 200 milliseconds. We know that normal is 120 to 200, or 3 to 5 little boxes. So it's a normal PR interval, but we need to make sure that that stays that way throughout the entirety of the rhythm, right? Because sometimes when you have a pause like this, we need to make sure that those pauses are not caused by P waves that are not conducting to the QRS. And so we kind of scan through, and I see we have P to QRS, P to QRS, P to QRS, P to QRS, and I look here to just make sure there's no P waves that I don't see that are not being conducted. I don't see that to be the case. So AV nodal function as I scan through the rhythm seems to be okay. And then what happens when the AV node sends that signal down to the ventricles and creates our QRS complex? Well, we said it was a wide complex rhythm, right? So if I look here, my QRS duration is about maybe 140 milliseconds, so just a little bit bigger than 3 small boxes, so it's wide. That's too long. We'll put arrows up, too long. My QRS complex, the axis of depolarization, is upright in lead one, and it's like isoelectric in AVF, so it's parallel to AVF, or excuse me, it's perpendicular to AVF, so it's going straight towards leads one, perpendicular to AVF. So kind of a leftward axis, but not quite. And so we said it's wide, so we look for a certain type of morphology. And what you have probably already noticed is that my QRS complexes in my lateral leads one, we have R prime, right? We have a little R prime. In AVL, we have a kind of slurry positive force. It takes a while for that to come back down to baseline. And you also see that same kind of slurry here in V5, right? Kind of slurs. You can see a little notching. That kind of tells me in the lateral leads that we have late forces going towards the lateral leads. And that happens when the left bundle branch is blocked, right? If left bundle is blocked, then that signal can't go down the left bundle, it'll go down the right, depolarize that territory first, and then by cell-to-cell gap junctions, head over to the left side, slowly creating that slurry QRS, and we're getting positive forces in my lateral leads 1, AVL, V5, and V6. We also notice that we no longer have that septal R wave, so we've lost loss of our septal R wave, and so that's also occurs because the left bundle supplies fibers to the septum. And so when you block the left bundle, you're also blocking the septal fiber, so you don't get the septal R wave. It's pretty cool. So what do we have? We have a left bundle branch block. Okay. Left bundle branch block. We look at our QT interval, right? And I just pick maybe 2 QRS complexes. I find the midway point between the two of them, and I make sure my T waves end by then, which they do. Last thing I do is I look for pathological Q waves, which tell me if there has been a previous myocardial infarction, which I don't see any, and I look for any active ST or T wave changes. Remember that in the setting of a left bundle branch block, you're going to use something called Sgarbossa criteria. And I don't see anything that meets Sgarbossa criteria. So now the last thing we need to do is we need to figure out what is going on with these early beats, right? So we know that, one, they are premature. So we need to figure out, are they PACs or are they PVCs? We can see that they're wide. They're wider than the normal beat. And so now I just need to figure out, is there a P wave in front of them? And so I look in front for P waves, and I say, well, I wonder if this is a P wave. Well, in fact, that's actually a T wave, right? It looks just like the normal T wave after each of those QRSs, and you can verify that down here, right? Look at this T wave, looks just like this T wave, right? They all look the same, okay? So I don't see any P waves hidden on top of that, and so in the setting of no premature atrial activity in a wide complex QRS, this is a premature ventricular beat or contraction, right? And that occurs twice, same thing. And so what do we get? We put this all together. What do we have? We have a sinus rhythm. We didn't calculate our rate. We can do that quickly. If I start, maybe this QRS lands here, so we got 300, 150, 100, maybe 75 beats per minute. So we've got a sinus rhythm at a rate of 75 beats per minute. We have a left bundle branch block, and we have 2 premature ventricular contractions. So I hope this helps, and leave any comments or questions that you have regarding the rhythm. And if not, thank you so much for supporting the channel. Feel free to like and subscribe if you want to see more, and we'll see you on the next ECG video. Have a great rest of your day.